of the valvular heart disease. We discussed last time aortic and mitral valve disease, and we touched on the important points. So we try to touch on the important points for tricuspid valve disease, infective endocarditis, prostatic valve disease, and the important points which you meet in clinical practice and come up in clinical examinations as well as in the multiple choice questions. So like mitral regurg, tricuspid regurg presents in two flavors. It can be secondary or functional, and that constitutes about 85% of patients with tricuspid regurg. But the examination is fond with asking you about primary tricuspid regurg, conditions in which the chordae, papillary muscles, right ventricle, as well as the leaflets of the tricuspid valve and the ring of the tricuspid apparatus is responsible for generation of tricuspid valve disease. So secondary tricuspid regurg occurs usually as a result of left-sided diseases, whether we are dealing with heart failure with reduced ejection fraction or preserved ejection fraction, or as a result of valvular disease on the left side of the heart. And there is a potential form that's coming forward now as a cause of secondary mitral tricuspid regurg, in which there is mitral regurg on the left side of the heart and tricuspid regurg on the right side of the heart, without the participation of significant pulmonary hypertension or right ventricular remodeling. So that's a new entity that we have to be aware of. Various forms of pulmonary hypertension through remodeling of the right ventricle, and by remodeling of the right ventricle, we mean dilatation of the tricuspid ring, tethering of the tricuspid apparatus, as well as displacement of the tricuspid papillary muscles away from being perpendicular to the tricuspid leaflets. All of these constitute the right ventricular remodeling that's responsible for the occurrence of tricuspid regurgitation as a complication of pulmonary hypertension. So it's not just the elevation of the right ventricular systolic pressure, because there is little correlation between the intensity or severity of pulmonary hypertension and the severity of tricuspid regurg, which limits the value of echocardiogram in depicting the level of elevation of the pulmonary artery pressure. That's why pulmonary hypertension should be diagnosed and followed up by right-sided cardiac catheterization, not because the echo is a poor quantitative method of estimating the degree of pulmonary hypertension, but because of the failure of the echo to produce a vivid picture of the pulmonary vascular resistance. Now, if we put this on the table and direct your attention to primary tricuspid valve disease, it can be rheumatic, usually associated with mitral valve disease, but because of the opioid epidemic that's now surveying the globe, infective endocarditis is becoming much more common than ever before. And this kind of infective endocarditis, although usually it's a benign form of infective endocarditis, but sometimes it's complicating a left-sided infective endocarditis associated with pulmonary emboli, septic pulmonary emboli, multiple pulmonary abscess. And despite that, usually medical treatment succeeds in combating this kind of infective endocarditis, although under exceptional circumstances, you need surgical intervention to deal with right-sided infective endocarditis. Epstein's anomaly we covered in the congenital heart disease, and we can have primary tricuspid regurgitation as a result of rheumatic fever or as a result of a complication of pulmonary valvotomy, and it can be the outcome of carcinoid, which produces a bad combination of pulmonary stenosis, occasionally pulmonary regurgitation, and tricuspid regurgitation. The association of pulmonary valve disease and tricuspid regurgitation perpetuates the tricuspid regurgitation. Now, because of the plethora of pacemaker implantation these days, we have problems with the pacemaker implantation in relation to the generation of tricuspid regurgitation, as well as the presence of ICD leads. And the pacemaker produces tricuspid regurgitation by multiple mechanisms. It can interfere with the valve closure. It can entangle the chordae tendineae of the tricuspid valve. It can perforate the tricuspid leaflets. and it produces dyssynchrony as a result of right ventricular apical pacing producing left bundle branch block, and this kind of dyssynchrony over the years produces right ventricular as well as left ventricular dilatation and tricuspid regurgitation. So tricuspid regurgitation can be the outcome of long-standing pacing for several years, 5 to 10 years. They find that the patient is getting right-sided heart dilatation, tricuspid murmur, as well as jugular venous distension in systole. Also, right ventricular biopsy after orthotopic heart transplantation can be a cause of primary tricuspid regurgitation. Now, it's important to pay attention to the tricuspid ring. On the left side of this diagram, you will have the right-sided structures, and this is shown in green, the dimension of the tricuspid valve. And any measurement of the tricuspid dimension in the apical four-chamber view that exceeds 40 millimeters or 4 centimeters in diameter in diastole or 25 millimeter per square meter body surface area constitutes tricuspid dilatation. And tricuspid ring dilatation, if it is associated with even mild tricuspid regurgitation, is an indication for surgical intervention. So that's very important, particularly of the extreme enthusiasm of doing a mitral valvotomy for every patient with severe or very severe mitral stenosis without paying attention to the right side of the heart. And I mean by this that patients that are indicated and tackled by mitral balloon valvotomy because the mitral score, like Wilkins score, is acceptable for these patients, pay attention to the tricuspid ring. If the tricuspid ring is dilated as evidenced by an increase of the diastolic dimension of the tricuspid ring in the apical four-chamber view beyond these figures, 4 centimeters or 21 millimeters per square meter body surface area, this means that you have to change your decision from mitral balloon valvotomy to surgery, because the tricuspid ring here should be shrunken by annuloplasty. Otherwise, you will open the mitral valve, improve the cardiac output, increase the venous return, and aggravate the tricuspid regurgitation. So these patients come after several years by severe right-sided heart failure, severe tricuspid regurgitation, and we get an operation that has a very high mortality rate in the range of 20 to 25%. So this pitfall, which is commonly encountered in our local practice here, should be carefully avoided. Now, the tricuspid ring can also be measured during the operation by using a ruler the distance between the anteroseptal commissure and the anteroposterior commissure, and during the operative surgery, or by using a three-dimensional unfaced view echocardiogram and a measurement of 70 millimeter of mercury. 70 millimeter is an indication of tricuspid annular dilatation, and this 70 millimeter between the anteroseptal commissure and the anteroposterior commissure exactly correlates with the 40 millimeter measurement in the apical four-chamber view. So this is an important point. Now, if you look into the guidelines for the intervention for tricuspid regurgitation, there is only one indication that's class 1 and one indication that's class 2A. So tricuspid surgery for severe tricuspid regurgitation is indicated for patients undergoing the left-sided heart surgery. So if you are operating on the mitral valve or on the aortic valve or on both, and at the same time you have an evidence of severe tricuspid regurgitation, it's a class 1 indication. Whether this patient is symptomatic from the tricuspid valve or not, because it's stage C or D, this is a class 1 indication for surgery, and it's the only class 1 indication for surgery in this context. And the only class 2A indication is tricuspid valve repair for mild or more secondary tricuspid regurgitation during left-sided surgery if the tricuspid annular dilatation is present or there is evidence of prior right-sided heart failure. So this is the importance of having annular dimension measured and seriously considered in the intervention on the left-sided heart valve. So even if there is evidence of mild or more than mild secondary tricuspid regurgitation, that's an indication for tricuspid valve repair to class 2A. And there is multiple class 2B indications for tricuspid valve repair for moderate secondary tricuspid regurgitation with pulmonary hypertension at left-sided heart failure. And if you have a previous operation for the left-sided heart failure during which the tricuspid regurgitation was not tackled, it's a class 2B indication to go again and tackle tricuspid regurgitation by tricuspid valve replacement or tricuspid valve repair for severe tricuspid regurgitation persisting with persistent symptom after prior left-sided heart surgery. Now, if we leave the secondary tricuspid regurgitation and direct our attention to primary tricuspid regurgitation, class 2A indication is surgery for severe primary tricuspid regurgitation that is unresponsive to medical treatment or is associated with progressive right ventricular enlargement and right ventricular dysfunction. So as you see, the indications for intervention in tricuspid regurgitation concerning in class 1 and class 2 indication are very restricted indications, but the value of measuring the tricuspid annulus and estimating even mild degrees of tricuspid regurgitation should be noticed. Now, if we direct our attention to the pulmonary valve, we discussed the pulmonary stenosis in the congenital heart disease previously, and then pulmonary regurgitation in a mild form or even in a moderate form is almost ubiquitous in even normal individuals. So in the short axis view, you will find a signal of mild to moderate pulmonary regurgitation as a common finding in normal individuals. But sometimes we get a significant primary pulmonary regurgitation. We discussed that when we discussed the surgical treatment of cardiology, when we mentioned that if you patch the outflow tract of the right ventricle, you cut across the pulmonary annulus, you create a tremendous tricuspid regurgitation, difficult to diagnose because it's associated with laminar flow without even turbulence. And the clue to the diagnosis is the presence of a short-lasting diastolic murmur associated with right ventricular enlargement. The MRI or MRA, as well as cardiac catheterization, might be more informative under these circumstances, but the context itself, cardiology, operation, patch across the outflow tract of the right ventricle, progressive right ventricular dilatation, think of tricuspid pulmonary regurgitation. Again, the same occurs in Ross operation. In Ross operation, you have a pulmonary autograft in the aortic position. And since it is in the aortic position, subjected to the high aortic pressure, pulmonary regurgitation occurs severely, and under these circumstances, it needs to be repaired. Also, carcinoid can be. So intervention is indicated in these conditions if there is evidence of severe pulmonary regurgitation associated with symptoms or signs of right ventricular dysfunction. In patients in which pulmonary regurgitation is not a primary event but secondary to pulmonary hypertension, obviously the treatment will be the treatment of the underlying etiology, that's the pulmonary hypertension, whether it's type 1 until type 2, 2, 3, 4, or 5. So it's important to pay attention to pulmonary hypertension, whether it's primary or secondary. Now we move into bacterial endocarditis. I direct your attention that the major criteria are classically two. That's evidence of bacteremia, persistent bacteremia, as well as evidence of echocardiographic involvement of the endocardium. The European guidelines several years ago added another third major criterion, and that's CT scanning in association or without the association of radionuclear imaging. So CT scanning with radionuclide leukocyte tagged, as well as CT PET scanning are important major criterion according to the European guidelines. And if you apply the Duke's criteria, so you need 2 major or 1 major and 3 minor or 5 minor criteria. Now, having said that, we move into case number 7, a 48-year-old man with bicuspid aortic valve. In 81, he had a second generation tilting disc valve, Yorkshire, not widely used nowadays. He remained in a good condition for 20-something years, and then in 2004, he had an ascending aortic aneurysm secondary to his bicuspid aortic valve. He had to redo the operation, changed the aortic valve Yorkshire by a Medtronic hole, as well as replacing his ascending aorta and the arch. Routine follow-up revealed that he has a 6 months history of fever, night sweats, weight loss. He had no dental manipulation, and he had no piercing of the gums of the mouth, and there is a colonoscopy with biopsy taken. He has temperature of 38, heart rate 92, blood pressure slightly wild pulse pressure, and hemoglobin is low, white cell count is normal, and platelet count is normal, and the blood culture was withdrawn. This is the ECG. Of course, the story is very persuasive of infective endocarditis complicating the prosthetic material and the aortic root that involves the Medtronic valve. Under these circumstances, your eye should be focusing on the presence of heart block in these patients. First-degree heart block can progress rapidly into second-degree and even third-degree heart block. Fortunately, in this electrocardiogram, there is no evidence of heart block. There might be an evidence of increased left ventricular voltage, but no secondary ST wave changes and no evidence of left atrial abnormality. Now, if you look into the parasternal long axis view, there is something. There is here. I hope you can see the arrow. Here you can see the shadow of the Medtronic hole valve. In the real time, it's working well. There might be some abnormality here in the right ventricular and the left ventricular outflow tract and in the root of the aorta. You cannot be sure unless you compare that with a baseline echocardiogram taken in the first few months post-operative, but unfortunately that's not available. You see here the aortic graft because the ascending aorta and the arch has been replaced. Now, if you look to the short axis view, your eye here is caught by maybe slight thickening of the aortic root, as well as some shadowing here, although this shadowing can be just the reverberations, but it directs your attention to something abnormal. And here you get a diastolic flow jet, which is much more than the washing jet. The washing jet, which is generated across the prosthetic valves in order to prevent the thrombi, very prominent in Sergio bileaflet disc valve, as well as in certain previously single disc valve, including the Medtronic hole. This jet is usually a short jet, is monochromatic without turbulence, and doesn't go into the left ventricle more than 1 centimeter or so. There might be more exaggeration here of the shadow seen in blue. But if you look into the next shadow, next echocardiogram that I will show you soon, you will find a few other changes. So in summary, this is a 40-year-old man with mechanical aortic valve replacement. He has a 6 months history of fever, night sweats, weight loss. His transthoracic echo reveals a mechanical aortic valve replacement with normal appearance, mild aortic regurg. He got empiric treatment of vancomycin, gentamicin, and rifampicin. Remember that we start rifampicin in a dose of 900 to 1200 milligrams per day, but 5 days after the start of gentamicin, because it's an inducer of the enzymes which metabolize gentamicin and vancomycin, although both of them are essentially metabolized in the kidney or excreted in the kidney. But anyhow, it should be started 5 days after that. So this triple antibiotic therapy was started, but after 24 hours, the patient was still febrile and the blood culture revealed nothing. So the question is, what is the best course of action at this time of the game? Repeat the transthoracic echo after 2 days, or order a transesophageal echo, or order a cardiac CT or an MRI, or refer to surgery. Obviously, the correct answer is B, order a transesophageal. To order a CT is not a bad idea, but usually we order the CT and MRI secondary after we have insufficient information from the transesophageal echocardiogram. You cannot refer the patient to surgery without having a proper anatomic and physiologic diagnosis under this circumstance. So here is the transesophageal echocardiogram, the left atrium, the aortic root, the diametronic horn valve, and this is the transverse sinus, which is located between the anterior wall of the left atrium and the posterior wall of the aorta, and you can see a cavity like a bird's head here. And if you put the color, you will find that there is extreme turbulence into it. If you put the color, you will find you'll find turbulence into this cavity, and then there is a small fistula that's eroding through the myocardium into the left ventricle. It's not a free transvalvular aortic regurgitation, but it's some form of an aortic regurgitation equivalent, with the blood moving from the cavity located in the transverse sinus of the pericardium through the cardiac fibrous tissue into the left ventricle as a form of fistula. And then if you would go to the short axis view, then you will find that this cavity is quite large with multiple septations and a variety of turbulence, with the fistula moving from the cavity in the transverse sinus into the left ventricle. So this table shows you the importance and the frequency by which we order transesophageal echo in patients with suspected prosthetic valve endocarditis. So usually there is at least 85% of patients with infective endocarditis, they need a transesophageal echocardiogram. It's a class 1 indication. It's a class 1 indication to get transesophageal echocardiogram if the transthoracic is non-diagnostic, or if there is complication or suspected complications, or if there is an evidence of intracardiac lead infection. But don't exclude intracardiac lead infection based on a normal transesophageal echocardiogram. The lead is long, it's covered by a membrane, and this membrane is harboring the infection. You don't see vegetations or thrombi along the lead, and despite that, everything should be gotten out from the patient, including the pulse generator and the leads, if there is any evidence or any suspicion of infective endocarditis, and we will come to that soon. And in addition, it's a transesophageal is a class 2A indication if there is evidence of Staph aureus bacteremia without a known source. If there is a known source for the bacteremia, it's a class 2B indication. If there is any suspicion of prosthetic valve were complicated by persistent fever, and if there is any suspicion of paravalvular extension of the infection and the TEE and TE are not informative, then this is a class 2A indication for cardiac CT, maybe CT PET scanning, because the hyperactivity of the inflammatory tissue will lighten up this area and facilitate the diagnosis. Another class 1 indication for transesophageal echocardiography in bacterial endocarditis is for patients undergoing surgery to monitor the procedure, the operative procedure all through. So this is a very common requirements in patients with infective endocarditis. When to interfere surgically in infective endocarditis, there is a lot of class 1 indication. This should be decided by a multidisciplinary team, but an early surgery is mandatory if the patient gets heart failure. So this is the primary indication. Heart failure that is the result of valvular dysfunction or a fistula or an aneurysm or a pseudoaneurysm. Any of these things that produce heart failure, class 1 indication for surgical intervention. Or if you get a resistant organism like Staph aureus or fungus infection, or if you get massive destruction of the cardiac tissue with the production of heart block, annular or aortic abscess, or penetrating lesions, or if there is evidence of persistent infection lasting for a week after appropriate antibiotic therapy, or even after the control of the bacteremia, you get a relapse of the infection, or if you get persistent vegetations despite appropriate antibiotic therapy with recurrent emboli. So all of these are class 2 indicate to class 1 indications. The class 2B indication, which is really controversial, is the size of the vegetation. If you get a vegetation more than 10 millimeter in length, with or without emboli, that's a class 2B indication. Sometimes the condition is obvious. You have a patient with left ventricular failure, severe aortic regurg, a vegetation that's 15 millimeter. Under these circumstances, it's obvious surgical indication. But sometimes the ventricular function is normal, valvular function is almost normal, and the vegetation size is 12 millimeter of mercury. Under these circumstances, everybody shies away from doing a prophylactic surgery to prevent the emboli. So it's a very flexible indication. So be aware that don't be caught with the decision that the size of the vegetation, if it is large, it's an indication for surgery. It's not unless there is a concomitant factor that enhances the decision to move towards indicating surgery. The European guidelines is putting the figure 20 for right-sided vegetations. Right-sided vegetations are usually more benign, but if the patient is having recurrent pulmonary emboli as well as persistent fever, evidence of a resistant organism, severe tricuspid regurgitation, and a large vegetation, and the figure here is 20 millimeter of mercury on the right side of the heart, then it's an indication for surgical intervention. Now, if we leave the native herbs and move to ICT or SEED, which is the cardiac implantable electronic devices that include the ICD and the pacemaker, if there is any evidence of SEED involvement, it's an indication of complete removal of the device and the leads. If there is an evidence of valvular infection by Staph aureus or a fungus, even without device involvement, it's an indication to a indication for removing the device. And even if the patient is undergoing surgery for infective endocarditis involving the valves, but there is no evidence of device involvement, this is still a 2A indication for getting everything out to sterilize the patient wait a week or 2 weeks, and then implant the device again in another position. So we'll put this aside and move to the important facts about the prosthetic valves. The prosthetic valve choice, after indicating that the patient is a candidate for prosthetic valve replacement, the second question will, which prosthetic valve should be used? And here are the indications are very flexible. Abroad, almost all the patients opt for using a bioprosthesis because they do not want to be trapped with the lifestyle limitations imposed by continuous use of anticoagulation. But here in Egypt, everything has to be explained to the patients and help him to make the choice in association with the treating physician. So the flexible indications is going with the age of the patient. If the patient is less than 50 years of age, it is reasonable to use mechanical valves if the patient is not a contraindication for anticoagulation. And also if the anticoagulation cannot be managed or undesirable by the patient, then she shouldn't get a mechanical valve. But if he is under 50, there is no contraindication for anticoagulation, then it's reasonable to choose mechanical valves under these circumstances. If the patient is above the age of 70, then you can use a bioprosthesis, and in between 50 to 70, you can use either a bioprosthesis or a mechanical prosthesis as the prosthesis of choice. If the patient is a youngster with a contraindication or undesirable use of oral anticoagulants, then a Ross operation in which a pulmonary autograft is put in the aortic position and an aortic homograft is put in the pulmonary position. This allows the patient to have the valve that's resistant to infective endocarditis with better hemodynamic performance, and there is no need for anticoagulation. Now, if you implant a prosthetic valve, then you follow up by echo. And the recommendation for follow-up by echocardiogram is to use an initial transthoracic echo after valve replacement by something like 1.5 to 3 months after the lapse of the post-operative hemodynamic disturbances, and maybe to repeat it after 6 to 12 months again when the left ventricular stunning is over. Under these circumstances, you get a baseline evaluation of the performance of the valve and the left ventricle, and you can repeat the transthoracic echo if there is any evidence, symptoms, or signs suggestive of valve dysfunction, or if there is inadequate information provided by the transthoracic echo, then you can do a transesophageal echo again for symptom or sign changes. And then in patients with bioprosthesis, it's recommended 2A recommendation is to repeat annually transthoracic echo after 10 years of implantation of the bioprosthetic valve. Many experts in the field started to repeat the transthoracic echo for bioprosthetic valve not after 10 years, but after 5 years. But the recommendation in the guidelines after 10 years. Now, again, this emphasizes the facts that I just alluded to, the effect of age on selection of the prosthetic valve below the age of 50. The recommendation is for patients to have mechanical valves. If the patient is above 70, the recommendation is to have a bioprosthesis, and in between you can use either. What about the antithrombotic therapy for patients with prosthetic valve? Let us go to the bottom here. Class 3 recommendation that's contraindicated is to use direct and oral anticoagulants in patients with mechanical valves. For mechanical valves, you use vitamin K antagonists, and the guideline is encouraging us to use single digits rather than a range. So you shoot for a single digit. You get guided by the range, but you opt for the single digit. An INR of 2.5 for mechanical aortic valve replacement, bileaflet or current degeneration with no thromboembolic risks. And the thromboembolic risks means atrial fibrillation, prior thromboembolism, left ventricular dysfunction, or evidence of hypercoagulability. Now, the goal is of INR is 3 for mechanical aortic valves with the risk factors that I just mentioned, or mechanical mitral valve. In the American guidelines, they insist on adding to the anticoagulants low dose of aspirin. The European guideline emphasizes the fact that aspirin is useful only for concomitant atherosclerosis, and it increases slightly the bleeding tendency in patients without atherosclerotic manifestation. But since most of the examinations are driven from American literature, so remember that we use, in addition to oral anticoagulants, particularly vitamin K antagonists, a small dose of aspirin in patients with mechanical valves, whether we are putting them in the mitral or in the aortic position. We use aspirin in small doses after bioprosthesis for aortic valve replacement and mitral valve replacement as well. Now, the controversy is essentially related to mitral valve repair. There is no uniform agreement about what to do after mitral valve repair. Some give anticoagulants for the first 3 months, maybe 3 to 6 months after bioprosthetic aortic valve repair with low bleeding tendency. Some give for mitral valve repair just aspirin from the beginning, and some surgeons wait for 1 week post-operative and then institute direct oral anticoagulants in these patients. So this is not supposed to be an examination question because of the controversy surrounding it. In patients with staph, the classic regimen is to use a combination of antiplatelet therapy, clopidogrel 75 plus small dose of aspirin for 6 months, stop clopidogrel and continue aspirin for life. And because of the occurrence of the thrombus, silent thrombi on the aortic valve under these circumstances, there is a recommendation of giving vitamin K antagonists for 3 months in TAVR patients with low bleeding risk. The on-X valve is sometimes available here in Egypt. It's a low thrombogenic valve made of ultra-pure forms of carbon and carbon, and it has a less thrombogenic tendency rather than the St. Jude or the other currently available valve. So the recommendations is to use the vitamin K antagonists and keep the INR between 1.5 and 2. It's very important that this is the low dose, the oral anticoagulants is associated with low dose aspirin. But more importantly, the FDA is mandating that these patients who are having the on-X aortic valve replacement should be on full anticoagulation for the first 3 months. So the INR of 1.5 to 2 applies after the first 3 months. In the first 3 months, full anticoagulation with INR of 2.5 for a range between 2 and 3. After the first 3 months, then you can decrease the dose of oral anticoagulants, keep the INR somewhere between 1.5 and 2 plus small dose of aspirin. Direct oral anticoagulants, including antithrombin as well as anti-active factor 10, are contraindicated for mechanical valve replacement because they do not act on the extrinsic pathway. So again, this emphasizes the previous points that I just alluded to. Vitamin K antagonists with range of INR between 2 and 3 for patients who are having bioprosthetic mitral valve or mitral valve repair, although I just pointed out the controversy and disagreement about the optimum method of anticoagulating patients with mitral valve repair. And at the same time, for aortic valve replacement, vitamin K antagonists for 3 to 6 months if there is a low bleeding tendency. Now, what about bridging? Bridging is the stopping the anticoagulation and stopping the oral anticoagulation and replacing it by heparin, some form of heparin, whether it is low molecular weight heparin or it is unfractionated heparin for some time, because that's a complicated issue. So the indication is very restricted under these circumstances. The only indication for this condition for bridging, which is a class 2A recommendation, is to bridge patients who are having a mechanical aortic valve with high thromboembolic risks, or old degeneration aortic valve, or a mechanical mitral valve. So apart from that, you don't need to bridge. In order to bridge, you stop warfarin 5 days before surgery. You start heparin within when the INR decreases below 2. You stop heparin 6 hours before surgery or 24 hours for low molecular weight heparin. This is before the operation. You do the operation, and after the operation, you start warfarin on the same day of surgery. You start heparin, unfractionated heparin, 24 hours after surgery or 48 hours for low molecular weight heparin, and then you DC heparin when the INR reaches a therapeutic level. So this complicated procedure mandated that we do not bridge except under one exceptional circumstance, and that's the presence of a mechanical aortic valve replacement with risk factors for thromboembolism or mechanical aortic valve mitral valve replacement. For patients undergoing minor procedures like dental extraction and cataract, to continue vitamin K antagonists without bridging. For patients undergoing a major operation, and at the same time he doesn't have this indication that I just mentioned before bridging, we just interrupt vitamin K for 4 or 5 days without bridging, and we bridge only for a very limited group of patients, which I just mentioned to avoid the complicated procedure of replacing oral anticoagulants by unfractionated or low molecular weight heparin. Now, what about the anticoagulation for patients with valvular heart disease in association with atrial fibrillation? A class 1 indication, rheumatic mitral stenosis of moderate or severe degree or very severe degree. So if you have rheumatic mitral stenosis that's severe, valve area below 1.5, remember the guideline doesn't indicate for mitral stenosis in particular what's moderate severity. The guidelines indicates that if you have a mitral valve area of 1.5 square centimeter or less, it's severe. If it's less than 1 centimeter square, then it's very severe. What's moderate is not indicated. Previously, we thought that if you have a gradient less than 5, there is no mitral stenosis or mild mitral stenosis. 5 to 10 is moderate and more than 10 is severe, but that's not supported by the recent guidelines. Neither the 2014 or the update in 2017 or the European that came in 2017. So it's not clear, but what's clear is that rheumatic mitral stenosis with atrial fibrillation is an indication for vitamin K antagonist, not for direct oral anticoagulant. If you have with mitral stenosis a left atrial dilatation but no atrial fibrillation, no anticoagulants. If you have a spontaneous contrast echo with mitral stenosis but no atrial fibrillation, no anticoagulants. Apart from this indication, you go with the Sheds VASC scoring and you can use any form of anticoagulation. Whether you use anticoagulation with vitamin K antagonists or Sheds VASC score of 2 or more for native aortic valve disease, tricuspid valve disease, or mitral regurgitation, or you use the DOAC as an alternative to vitamin K in these same kind of patients, everything is accepted. What's not accepted is to use DOAC in patients with severe or moderately severe rheumatic mitral stenosis in association with atrial fibrillation. So mechanical valves and rheumatic mitral stenosis indication for vitamin K antagonists. Valve-in-valve is now the fashion for both the aortic and the mitral valve bioprosthesis, and this increases the use of the bioprosthesis since the dysfunction that occurs after 10 years or 10 to 15 years in these patients doesn't need another operation with mediastinal incision. Under these circumstances, you can put a valve-in-valve. What's being used is a balloon expandable Edward Sapiens 3 valve. We don't use the core evolute valve because it's long and protruding into the left atrium, cannot be reversed in its direction. So this can be used in the mitral as well in the aortic position. The guidelines is clear about the valve-in-valve in the aortic position. It's indicated in patients who are symptomatic with degenerated valve in the aortic position or the mitral position, and in whom a reoperation is not anticipated to improve the patient. So valve-in-valve is used as a reparative process for the degenerated bioprosthesis, and that helps people to choose a bioprosthesis even before the age of 50, as we indicated. So we have our last case for the valvular disease, and then we'll have questions after that. Case number 8 is a 50-year-old woman with rheumatic valve disease. In 2001, she got a percutaneous mitral valve valvotomy. Within few months, she got restenosis. So 4 years later, she got a bileaflet mechanical mitral valve replacement. She has 1 year history of progressive shortness of breath, diagnosed as COPD, treated for the COPD without evident improvement. 1 month ago, she was diagnosed as having pneumonia, got antibiotics, and still did not improve. Admitted with respiratory distress, heart rate 100%, she is shocked. Blood pressure is 60 millimeter of mercury. There is absent heart sound, so it's clear that she got problems with heart sound opening or closure. White cell count is normal, serum creatinine is normal, and ESR is normal. She has an INR of 1.6. So this is a mitral valve replacement bileaflet, so it's supposed to have an INR of 3. So its INR is 1.6. This points to the occurrence. The short history as well as the inadequate anticoagulation pointed to the occurrence of thrombosis. You can get obstruction across the mitral valve or the aortic valve because of a thrombus, of a venous, of vegetation, or even of a calcification in case of bioprosthesis. And you have a wide differential diagnosis for patients on whom we have a large gradient across the mitral or the aortic valve, and these include number one, patient prosthesis mismatch, in which the prosthesis is smaller for the size of the patient, and we'll come to that, or you get obstruction by these different things. So number three, you get increased flow without obstruction, without patient prosthesis mismatch, and the increased flow can be the result of paraprosthetic regurgitation or hyperkinetic circulation, or you get a pressure recovery phenomena, which we explained last time. So these are the four differential diagnoses for the existence of a gradient across the mechanical or the bioprosthesis. Now this is a transesophageal picture, and you can see a shadow here, probably preventing the prosthetic valve from, the bileaflet prosthetic valve from opening, and even preventing it from closing as well. And if you put the color, you get amazed by the turbulence with the blood trying to move from the left atrium towards the left ventricle under these circumstances. And here is the gradient. You get a margin, a mean gradient across the mitral valve of 15 millimeter of mercury. That should not exceed 5 millimeter of mercury. The important thing is to have a baseline gradient by which you compare the results at the time of presentation of the patient with the problem with the baseline gradient. But anyhow, the gradient which is accepted for the aortic valve should not exceed the baseline by 10 millimeters of mercury, and for the mitral valve should not exceed the baseline by more than 5 millimeters of mercury. But again, the gradient can be the outcome of patient prosthesis mismatch under these circumstances. This is the commonest cause. Under these circumstances, you measure the effective orifice area by the continuity equation, and the two figures that you need to remember is 0.65 for the aortic valve and 0.9 for the mitral valve. These are the two figures by which we diagnose patient prosthesis mismatch, and this is the commonest cause of a gradient across a prosthetic valve. The second common cause of a gradient is the presence of obstruction, whether by a venous or a thrombus or a vegetation or a calcification. Under these circumstances, you should have an evidence of limited mobility of the valve disc or valve leaflets, and this can be done fluoroscopically or done by a variety of measurements by echocardiogram. And the third method in which creates a gradient, factor that produces a gradient is if you have a paravalvular regurgitation or a hyperkinetic circulation, and the fourth one is the pressure recovery phenomenon. So here it's evident that the patient got some obstruction, and the echo shows that there is something sitting here on the top of the valve preventing it from opening and creating the obstruction. So if you summarize the situation with these patients, is a 58-year-old woman with bileaflet St. Jude mechanical mitral valve, presents with symptoms of dyspnea and evidence of valve thrombosis. She is shocked. Which of the following is supported by the current guideline recommendation? She preferred the treatment with intravenous unfractionated heparin with re-evaluation for thrombus size after 24 hours. Or either emergency surgery or slow infusion of low-dose fibrinolysis is appropriate, or presentation with class 2 symptoms favors the treatment or emergency surgery, and D is thrombus size more than 1 centimeter favors the treatment with fibrinolysis. The correct answer is B, and I will go through them starting from A. The preferred treatment is intravenous unfractionated heparin. We use this for valve thrombosis in bioprosthesis, not in mechanical prosthesis. Mechanical prosthesis needs surgery or needs thrombolytic therapy rather than anticoagulants. C, presentation with class 2 symptoms favors treatment with emergency surgery. Usually we resort to emergency surgery, particularly with class 4, class 2 or 3, class 1, 2 or 3. If there is other factors that hamper the indication of surgery, is an indication for fibrinolytic therapy, and we will come to that in the last slide. A thrombus size of more than 1 centimeter favors fibrinolysis. The guidelines indicates that a thrombus size less than 0.8 of a centimeter favors the thrombofibrinolysis. So 1 is considered bigger than what is usually responsive to fibrinolysis. So the guidelines statements for valve thrombosis is that urgent initial treatment with either slow infusion of low-dose fibrinolysis or emergency surgery is recommended for patients with mechanical valve presenting with symptoms and signs of valve obstruction. And the guidelines indicates a slow infusion of low dose. Low dose is 1,500,000 units of 500,000 units of streptokinase given over 1 hour, or 100 milligrams of TPA given over 1.5 hours. So this is what is recommended by the European guidelines. If the patient is having the same problem but on a bioprosthesis with valve thrombosis and he is stable and there is no contraindication for anticoagulation, then it is reasonable to initiate vitamin K antagonist as a therapeutic line under these circumstances. This is the last slide, which indicates what favors surgery and what favors fibrinolysis in patients who are having valve thrombosis. And if you look to the right-sided column, what favors fibrinolysis is unavailability of surgical experience, if there is a high surgical risk, if the patient have a knee class 1, 2, or 3, if the patient is having a thrombus size of equal or less than 0.8 centimeter. So these are the only 4 indications which favor fibrinolysis. If surgical expertise is present, if the surgical risk is low, if there is contraindication for fibrinolysis, if the clot size is big, if there is left atrial thrombus, or if there is another surgical indication, then all of these favor surgery and under these circumstances. So I stop at this stage. I'm sure there are unanswered questions in valvular diseases, so I'm ready to respond to your questions as you like. Okay.
شكرا يا دكتور محمد، ننتظر الأسئلة.
ايوه محمد.
يا دكتور محمد، هو لسه ما فيش أسئلة جت.
طيب نعم.
سؤال. اوكي.
يبقى كلهم فاهمين كل حاجه 100%.
لا، في سؤال بيسأل عن fibrinolysis.
قبل ما نقول الاسئله، دلوقتي دي المحاضره رقم 22. We covered a huge amount من الكوريكولم and now we have شهر اكتوبر شهر ديسمبر امتحان متأجل من شهر 5 وامتحان بتاع شهر 10 و11. So we will stop at this stage until يوم 4 ديسمبر، حيث نبتدي عندنا حوالي 12 إلى 15 محاضرة عشان نكمل الكوريكولم. فالمحاضرة اللي جاية هتبقى يوم 4 ديسمبر الساعة 7 مساء. العشاء بيبقى على 6:15 في الوقت ده. So 7 هتكونوا صليتوا العشاء ودعيتوا ربنا إنه يوفقكم وكل حاجة بقت تمام. So we will stop after this lecture and after we answer this question to get a good chance إنكم كنتوا تريفايز الموضوعات المختلفة من coronary artery disease, arrhythmia, valvular disease, congenital heart disease, clinical examination اللي احنا اتكلمنا عنها, heart failure, وكل ده هو يبقى جاهزين لمحاضرات عن hypertension, pulmonary hypertension, pericardial disease, aortic disease, venous thromboembolism, peripheral arterial disease, and then evaluation of the cardiac patient by CT, MRI, exercise test, as well as radionuclide. So this will cover the major part of the curriculum. ECG as well as echocardiogram related to احمد الضماطي والاستاذه الدكتوره وفاء العروسي they are much more capable than me ان هم يوروكوا الحاجات دي. So let's answer the questions.
اوكي، اول سؤال بيسأل على dose of fibrinolysis in a pregnant female with valve thrombosis.
اوكي، طبعا ان هو الدوز اوف فايبرينولايسيس هي ذا سيم فور بريجننت فيميل ولا نون بريجننت فيميل، لكن الريسك طبعا بيزيد مع الفايبرينولايسيس. So we try if the pregnant female is having a bioprosthesis to opt for anticoagulation rather than fibrinolysis. But still low dose slow infusion دي غير الدوز بتاع زمان. احنا كنا زمان بندي الدوزز اللي هي for 9 hours، ندي 1 million every hour for 9 hours has been reduced. طبعا TPA is more effective than streptokinase، لكن streptokinase هي 1,500,000 وحدة في مدة ساعة. TPA بندي بولس of 10 milligrams في الأول and then we have 90 milligrams to be infused over 90 minutes whether you are dealing with pregnant or non-pregnant female. There is no specific indication for pregnant female.
اوكي، السكند كويستشن بيسأل في السلايدز اللي حضرتك عرضتها سلايد 78. كان عايز حضرتك تكومنت على النيو اورال انتي كواجولانتس يوزج ان النيتيف فالف.
فاهم 78 ايه؟
السلايدز اللي حضرتك عرضتها كان في سلايد 78 اللي كان حضرتك اتكلمت على اليوز اوف نواكس في النيتيف فالف ديزيز.
احنا بنستخدم الدايركت فيتامين كي انتاجونست في النيتيف فالف ديزيز في حاجه واحده، روماتيك mitral stenosis of moderate or extreme severity. Under these circumstances you need ان العيان ياخد فيتامين كي انتاجونست if he's having atrial fibrillation. So لازم يكون روماتيك، لازم يكون mitral stenosis of certain severity، ويكون عنده atrial fibrillation. اي حاجه تانية فيها atrial fibrillation سواء هي tricuspid valve او pulmonary valve او aortic valve او mitral regurg you can use vitamin K antagonist or you can use direct oral anticoagulant. في سؤال بنتسأله كتير جدا، how about the bioprosthetic valve؟ اذا كان الميكانيكال فالفز مفيش اختلاف، mechanical valve aortic or mitral position vitamin K antagonist not دواء. طب البيولوجيكال فالفز البايوبروسيزس، البايوبروسيزس احنا بعد الثلاث اشهر الاولانيين اللي احنا ممكن نستخدم فيهم لودوز اسبرين او نستخدم فيهم اورال انتيكواجولانتس فيتامين كي انتاجونست. It's not the guidelines but all the experts agree that we can change vitamin K antagonist بعد 3 اشهر في البايوبروسيزس in any position الى direct oral anticoagulant. There are reports successful وانا اعتقد انها will be included in the coming guideline. So بالنسبه للنيتيف فالفز مفيش بروبلم ان احنا بنستخدم الاورال انتي كواجولانتس في كل حاجه ما عدا الميترال ستينوزس of moderate severity or advanced severity في وجود الاتريال فايبريليشن. لكن من غير وجود الاتريال فايبريليشن there is no indication ان احنا نستخدم الانتي كواجولانتس في العيان. بالنسبه للبروستاتيك فالفز ميكانيكال فالفز always vitamin K antagonist always warfarin. اذا كان العيان عنده atrial fibrillation زائد ان هو بايوبروسيزس عدت فيها الثلاث اشهر we can use direct oral anticoagulants. The role of anticoagulants in atrial and bacterial endocarditis. There is no role in bacterial endocarditis of oral anticoagulants of any kind, except in one circumstance. إنها ما تكونش infective endocarditis، يعني تكون marantic endocarditis. العيانين اللي عندهم adenocarcinoma أو عندهم long standing collagen disease، العيانين دول هم عندهم endocarditis but not infective endocarditis. If these patients are having an embolic manifestation, then it's an indication for anticoagulation. Make sure that the blood culture is negative and the clinical picture is not compatible with the diagnosis of infective endocarditis by the Duke's criteria. زي ما قلنا الديوكس criteria الميجور كرايتيريوم بقوا 3 ما بقوش 2.
السؤال اللي بعد كده بيسأل على choice of treatment for prosthetic valve thrombosis. هل هيفرق whether البروستاتيك فالف ده رايت سايدد او ليفت سايدد؟ هيفرق في اختيار التريتمنت؟
طبعا يفرق جدا. خد بالك ان احنا عاده الليفت سايد وي اوبت فور سيرجري. ليه؟ لانك جيف ثرومبوليتيك ثيرابي. الثرومبوليتيك ثيرابي comes at the expense. It's easier طبعا، لكن comes at the expense of producing cerebral hemorrhage. لانك انت بتفرمنت left sided thrombus, it will go into the brain, produces an infarction in the liaison of anticoagulation. This infarction very liable to the cerebral hemorrhage. So this is the big problem. عشان كده هو بنقول اذا توافر حاجه من اربعه، مفيش سيرجيكال اكسبرتايز، دي نمره واحد. لو عندي سيرجيكال اكسبرتايز يعني في جراح ومتمرن على انه يفتح العيان ده اللي هو شوكت، يبقى في الجراحه مفيش شك في ذلك. الحاجات الثانيه ان هو يكون فانكشنال كلاس 1 2 3 مش 4، وبالاضافه الى كده ان الثرومبس سايز سمول، في شروط زي ما انتم شايفين. انما الاغلبيه بتروح للجراحه اذا توفر الجراح. الرايت سايد اندوكاردايتس هنا ما عندناش بروبلم غير ان في ثرومباي هتروح اللنج، واحنا عارفين اللنج از ريتش ان بلازمين، وبالتالي they will dissolve. So patients with prosthetic valve thrombosis عاده احنا بنحط في tricuspid valve bioprosthesis عشان نقلل الشانس اوف thrombosis. لكن sometimes you put a mechanical prosthesis. الميكانيكال بروسيسز اللي احنا بنحطها عاده بنحاول commonest indication في الحاجات هي infective endocarditis. فانفكتيف اندوكاردايتس بنبريفير ان احنا نحط هوموجرافت عشان البوسيبيليتي بتاعته انه يبقى ري انفكتد اقل. او اذا ما كانش الهوموجرافت افيلابل زي فري ستايل مثلا، بنحط ستنتلس ميكانيكال بروسيسز وزنه اخف وبالتالي supported by the necrotic tissue. طبعا لو حطيت ميكانيكال فالف او بايوبروسيسس من الاثنين دول هم لايبل تو ثرومبوسس. الثرومباي ده هو لو كونت على بايوبروسيسس usually anticoagulation العاديه can deal with the problem. If it is a big thrombus or if the anticoagulation didn't work, then thrombolytic therapy is an indication. Surgery comes when you get failure from anticoagulation or fibrinolytic therapy for right-sided valves. So this is different طبعا. هو اللي سأل السؤال عارف انها different.
فاهم. اوكي. السؤال اللي بعد كده بيسأل على risk of stroke with fibrinolysis.
risk of stroke is high with fibrinolysis. كل ما يبقى الانديكيشن بتاع فليمزي يعني ما تحققتش الاربع شروط، يعني مثلا الثرومبس سايز اكثر من 0.8، او العيان هيمودايناميكالي فيري انستيبل، او في previous thromboembolism. If you have a previous thromboembolism, the possibility of a next thromboembolism in the coming few days and maybe 1 or 2 weeks is very much increased. So under this circumstance, if you get a stroke نتيجة الثرومبس قبل ما تعمل أي حاجة, and then this stroke is producing cerebral hemorrhage or a large bland infarction, is a contraindication to thrombolytic therapy. It's also a contraindication for immediate surgery unless the patient is hemodynamically unstable. But if the patient is not having a big stroke, a big bland infarction, and does not have hemorrhage, then you can send the patient to surgery right now. So there is no delay. If there is a stroke, لأنه حصل thrombus وحصل stroke, the patient is available for surgery if the stroke is bland, is not hemorrhagic, and is not producing a major neurologic deficit. يعني العيان مثلا مش ما عندوش hemiplegia and aphasia، لكن عنده monoplegia, then he can go to surgery without delay. If there is a major bland stroke, non-hemorrhagic stroke, or cerebral hemorrhage, we wait for a month. إذا كان hemorrhage, you should consult the neurosurgeon as well.
السؤال اللي بعد كده بيسأل عن bridging therapy during perioperative period في patient on vitamin K. perioperative period in a patient on vitamin K antagonist for mechanical prosthesis, which is preferred, the low molecular weight heparin or the unfractionated heparin.
كلاهما بنستخدمهم، يعني واحد على وارفرين. المهم انك انت بتعمل 3 حاجات قبل العمليه، 3 حاجات بعد العمليه. الاول تتاكد ان العمليه محتاجه كده. اذا كانت ماينر اوبريشن مش محتاجه انك توقف فيتامين كي خالص. اذا كانت انها اوبريشن ما هواش انديكيت فيها البريدجنج، يعني ما هواش ميكانيكال فالف او ابورتيك فالف وسترومبي امبوليك ريسك، يبقى مش محتاج انك انت تبريدج. قررت انك تبريدج، قدمت بريدج بقى في 3 حاجات تعملهم قبل العمليه، 3 حاجات بعد العمليه. 3 حاجات اللي قبل العمليه انك هتوقف الوارفرين قبلها ب5 ايام. بعد ما توقف الوارفرين تستنى فتره لغايه الاي ان ار ما يقل عن 2، and then you start العيانين على يا اما انفراكشنيتد هيبرين يا اما لو مولكيولار ويت هيبرين. لو مولكيولار ويت هيبرين لونج اكتنج، فلازم توقفه قبل البروسيديور ب 24 الى 48 ساعه. انفراكشنيتد هيبرين شورت اكتنج، لازم توقفه قبل العمليه ب6 ساعات. وبعد كده تعمل العمليه. النقطه اللي بيحصل فيها اغلب الغلط اللي هو بعد العمليه. بعد العمليه اذا كان العيان خرج من العمليات 10 الصبح، الساعه 8 9 بالليل تبتدي له على وارفرين. هياخد وقت عشان يوصل للثيرابيوتيك اي ان ار. تبتدي بقى بعد كده هو على هيبرين لو مولكيولار ويت هيبرين اور انفراكشنيتد هيبرين. بعد قد ايه؟ هنا التريك ايه؟ انك اذا كنت هتدي لو مولكيولار ويت هيبرين لازم تتاخر شويه. طب ليه هتتاخر شويه؟ عشان لو حصل بليدنج وانت عاوز تريفرس ايه ب الانتاجونست بتاع الهيبرين، في الحاله دي هي الانتاجونست ده هو does not work مع low molecular weight heparin as efficiently as with unfractionated heparin. So we start after الوارفرين ما ابتديناه ليله العمليه، بنبتدي ب 24 ساعه نبتدي الهيبرين، نبتدي بعد 48 ساعه اللو مولكيولار ويت هيبرين. and then we wait بالاثنين مع بعض لغايه ما الوارفرين يوصل للثيرابيوتيك اي ان ار. وقف الهيبرين سواء انفراكشنيتد او لو مولكيولار ويت هيبرين، وفي الحاله دي هي نكمل بعد كده بالانتاج. بما انها بتاخد much effort, much time, much thinking about, and then at the same time الايرور وارد فيها. عشان كده we don't bridge except in one certain circumstances، اللي هي حاجه واحده اللي هي كلاس 2A اللي احنا قلنا aortic valve old generation او aortic valve مع ثرومبو امبوليك ريسكس من الاربعه اللي احنا قلنا عليهم، او mitral valve. هم دول اللي احنا بنبريدج معاهم، خصوصا لو العيانين دول عندهم atrial fibrillation. apart from that يا اما ما بنوقفش زي دنتال اكستراكشن او كاتاراكت اكستراكشن، يا اما بنوقف 4 ايام and we don't bridge ونرجع الوارفرين تاني when hemostasis is secure.
اوكي، في سؤال بعد كده برضو بيسأل على البريدجنج، بيسأل هل البيس ميكر امبلانتيشن از لو اور هاي ريسك فور بليدنج؟ يعني هنعمل بريدجنج ولا لا مع البيس ميكر امبلانتيشن؟
ده البيس ميكر امبلانتيشن ولا كانه اي حاجه خالص، وبيكونتينيو العيانين اللي على وارفرين ويمبلانت البيس ميكر وناخد بالنا من الهيموستاسيس في البوكيت، وما احناش بنخاف من الهيماتوما. طبعا لو واحد بيجنر وخايف من الهيماتوما في الحاله دي بيضطر ان هو يوقف الوارفرين. البريدجنج يمكن انتوا ما سالتوش البريدجنج او النو بريدجنج في الدايركت اورال انتي كواجلنتس. في الدايركت اورال انتي كواجلنتس كلهم شورت اكتنج، وبالتالي احنا من اللي بيحكمنا بقى هنا هو العيان هاي ثرومبوتيك ريسك ولا هاي بليدنج ريسك. اذا كان العيان على ريفاروكسابان او ايبكسابان او اندوكسابان او دابيجاتران وهو هاي بليدنج ريسك، يبقى في الحاله دي هي بنوقفها لمده 4 ايام او 5 ايام. اذا كان هو هاي ثرومبوتيك ريسك بنوقفها لمده يوم واحد. So this is the recommendation and it's easy and straightforward. There is no bridging. بنرجع بعد كده هو once hemostasis is secure مع السيرجن اللي هو عمل العملية within 1 or 2 days post operative. So it's easier. لكن فيتامين كي لو هنبريدج it takes 6 steps. 3 قبل العملية، 3 بعد العملية.
اوكي، سؤال بعد كده بيسأل على anti coagulation in mitral valve prolapse also after repair of mitral valve prolapse.
Anticoagulation for mitral valve prolapse لو في recurrent thromboemboli، لكن mitral valve prolapse باي سي ما بنديلوش anticoagulation. زمان كنا بنعتقد ان هو بالديسكتنج مايكروسكوب في بوكيتس في mitral valve prolapse عليها ثرومباي فكنا بنديهم aspirin, but this is not the recommendation in the guidelines. But if the patient gets thromboembolic episodes, it's an indication for anticoagulation. Obviously, if the patient is in atrial fibrillation, you go by the Shatz-Vasc score for mitral valve prolapse, and then mitral stenosis. The mitral stenosis of rheumatic origin. There were mitral stenosis due to valve calcification. It's not an indication for vitamin K antagonist. إذا كان mitral valve repair أنا قلت لكم mitral valve repair مفيش ريكومنديشن واضحة. في كذا بوليسي كل سنتر بيتبع بوليسي. في ناس بتدي للعيانين اللي هم low dose aspirin right from the beginning. أو ناس بتدي فيتامين K antagonist for several weeks and then continue with low dose aspirin. وفي جراحين ما بيديش حاجة خالص لغاية العيان يبقى عنده hemostasis and put him on apixaban on Eliquis 5 ملغ مرتين في اليوم. أو smaller dose in case you need a smaller dose بالطريقة اللي انتوا عارفين. So for mitral valve repair, this will not be a question because there is controversy and there is no clear recommendation. ليه ما فيش clear recommendation? No sufficient studies. No sufficient studies for repair. لكن بالنسبة للحاجات الثانية سواء ميكانيكال فالف أو الريسك أو ويتش فالف أو بايوبروستيزيس فيرسس ميكانيكال الكلام فيها واضح. It's confusing أنا ما فيش شك في ذلك لكن if you sit the exam you have to revise these things before going to the exam.
اوكي سؤال بيسأل عن risk of prosthetic valve thrombosis in case of fresh blood transfusion.
Okay, I don't know an answer for this question. I don't know something specific about thrombosis. If there is a thrombus, it should be treated the same way. مفيش حاجة specific للبلاد transfusion. إلا لو هو قال لي إيه اللي specific في البلاد transfusion اللي هيحدد الثرومبوسيس. Unless you are making thrombosis مثلا عيان عنده leukemia وعنده thrombotic tendency وبياخد blood transfusion for anemia. Sickle cell can produce thrombosis as well as bleeding and blood transfusion, but even in sickle cell transfusion قليل جدا غير الثلاسيميا. وبالتالي it's the same. It is the same. طبعا لو في bleeding tendency في عيان اللي هو عنده thrombotic tendency and bleeding tendency من DIC أو thrombotic thrombocytopenic purpura, then the treatment will be different. It will be a complicated issue not covered by the guideline.
اوكي في سؤال بيسأل عن ال anticoagulation in patient with AF and infective endocarditis.
We anticoagulate the Shatz-Vasc score, no doubt about it. If the patient is having atrial fibrillation and the atrial fibrillation lasted for more than 48 hours or even 24 hours to 48 hours, the controversial, can definitely after 48 hours and satisfies the Shatz-Vasc score is an indication of anticoagulation. Patient should have antibiotic therapy to cover it as early as possible, no delay, because the thromboembolism بيحصل في bacterial endocarditis early on in the first week. But you cannot wait إذا كان في atrial fibrillation لأن thromboembolic tendency will be great. So we go by the atrial fibrillation, we ignore the bacterial endocarditis. But if the patient is having atrial fibrillation of definitely less than 24 hours, then we postpone this until we give a good course of antibiotics, and then if the atrial fibrillation reaches the threshold of 48 hours, we start with anticoagulation.
يعني احنا مش هنحتاج ان exclude the presence of mycotic aneurysm قبل ما ندي anticoagulation في عين infective endocarditis.
No, you cannot do that because ما فيش أي كرايتيريا تقول لو أنت شفت mycotic aneurysm إيه السايز اللي هو بيرابشر فيه؟ أنت خايف من الرابشر. ما فيش كرايتيريا أبدا تقول which mycotic aneurysm can rupture. If you discover mycotic aneurysm لأن العيان بقى عنده manifestations يبقى في الحالة دي يعني you plug the mycotic aneurysm and continue the anticoagulation. We don't screen patients for mycotic aneurysms لكن the patient gets a neurologic manifestation that you image the brain arrhythmic aneurysm
دول الطوارئ.
أو we block the aneurysm. Under this circumstances, we continue anticoagulation except when there is cerebral hemorrhage sometimes. So we don't مش كل عيان accurate.
اوكي تمام. هو اخر سؤال هو بره نطاق المحاضره، هو بيسال عن اللاكتيشن ان بيريبارتم كارديوميوباثي.
Lactation in peripartum cardiomyopathy, the patient is having peripartum cardiomyopathy, there is no contraindication that the mother lactate. لكن the problem ان هو التريتمنت اللي موجوده هذا هو هتبقى ما انتش هتدي anticoagulants. Bromocriptine is no contraindication for lactation because we sometimes give bromocriptine, but the peripartum cardiomyopathy, particularly ventricular function, doesn't recover is a contraindication for subsequent surgery, and if it recovers, possibility of subsequent pregnancy having peripartum cardiomyopathy is still in the range of 30%, but there's no contraindication for lactation.
اوكي شكرا يا دكتور محمد، ده كان اخر سؤال. شكرا لحضرتك.
شكرا.